Many diagnoses carried out in medical lab practices are done majorly using blood sample. This blood sample can be collected venously through median cubital vein. The median cubital vein is one of the important contents of an important anatomical area known as cubital fossa. I welcome you back to Joen Academy. We will be discussing in this video the cubital fossa. We will talk about the location, its boundaries, contents of this area, and also some clinical implications associated with this anatomical area. Sit tight and have fun. The cubital fossa is a small triangular area located on the anterior surface of the elbow, with the apex of the triangle pointing distally. It serves as a transition area between the anatomical arm and the forearm and conveys several important structures between these two areas. Just as we stated earlier, the cubital fossa is triangular in shape and it consists of three borders, a roof, and a floor. The cubital fossa is bounded laterally by the medial border of the brachioradialis muscle. Medially, it is bounded by the lateral border of the pronator teres muscle. Superiorly, it is bounded by the horizontal line drawn between the epicondyles of the humerus. The roof of the cubital fossa is made up of bicipital aponeurosis, fascia, subcutaneous fat, and skin. The floor consists of brachialis muscle, which lies proximally, and supinator muscle, which lies distally. Having known the location and borders of this anatomical area, let's delve into the various structures that can be found in it. Like we stated earlier, cubital fossa is a passageway for structures to pass between the upper arm and the forearm. It contains the following structures from the lateral to the medial direction. The first is the radial nerve. The radial nerve travels along the lateral border of the cubital fossa, divides into superficial and deep branches. It gives a motor and sensory supply to the posterior forearm and hand. The next content is the biceps tendon. Biceps tendon passes centrally through the cubital fossa and attaches the radial tuberosity immediately distal to the radial neck. It gives rise to the bicipital aponeurosis, which contributes to the roof of the cubital fossa. The next structure is the brachial artery. At the apex of the cubital fossa, the brachial artery bifurcates into the radial and ulnar arteries. The medial nerve is the most medial structure. It travels medially through the cubital fossa, exiting by passing between the two heads of the pronator teres. It has a motor and sensory function in the anterior forearm and hand. Importantly, the roof of the cubital fossa also contains several superficial veins, which one of them is the median cubital vein. The median cubital vein connects the basilic and the cephalic veins and can be accessed easily. Like we stated in the prelude of this video, the median cubital vein is the common site for blood collection used for clinical diagnosis. An important mnemonic can be used to remember the contents of the cubital fossa. This mnemonic is: really need beer to be at my nicest. Really need stands for radial nerve. Beer to stands for biceps tendon. Be at stands for brachial artery, whereas my nicest stands for median nerve. Now, straight to the clinical importance. The first is supracondylar fracture. It is a fracture of the distal humerus. This fracture is typically transverse or oblique, and the most common mechanism of injury is falling on an outstretched hand. Supracondylar fracture is common in children than in adults. Contents of the cubital fossa are damaged in this fracture. Damage to the brachial artery, if not repaired, can cause Volkmanns Ischemic contracture, whereby there is an uncontrolled flexion of the hand as the forearm flexor muscles become fibrotic and short. There also can be damage of the anterior interosseous nerve. Anterior interosseous nerve is just a branch of the median nerve. Also, ulnar or radial nerve can also be damaged. The anterior interosseous nerve can be tested by asking the patient to make an OK sign, testing for the weakness of the flexor pollicis longus. The Gartland classification is used for these fractures, where we have type 1, type 2, and type 3. Type 1 is minimally displaced. Type 2 is displaced but with an intact posterior cortex. Type 3 is completely off-headed. Type 1 can usually be managed conservatively with an above elbow cast, whereas type 2 and type 3 require surgical fixation with crossed bicortical K-wires. Also, the median cubital vein is an important vein for venepuncture, and it is located in the cubital fossa. Thank you so much for watching up till now. Support Joen Academy by clicking on the subscription button. Please share and leave a comment. God got you.